Sure.
Welcome back to A Conversation with Carl. Remember to like, follow, and subscribe for the latest content. Today, we're going to discuss the serious issue of medical ethics. Most people have been to a doctor and understand the sometimes helpless feeling that comes over us when we know we need to put our lives into the hands of the doctor. Our hope is the doctor is not only competent, but also follows a code of ethics set forth by a combination of state laws, boards, and national medical associations. This conversation is timely as New York Governor Kathy Hochul signed New York's Medical Aid in Dying Act, allowing terminally ill, mentally competent adults with a prognosis of 6 months or less to live to legally obtain and self-administer prescription medication to peacefully end their lives. This law goes into effect in New York on August 5th. That is a lot to unpack. Luckily, to help us make sense of and discuss the ethical implications of this law, as well as medical ethics in general, we are privileged to be joined by Dr. Ezra Gabbay, professor and clinical ethicist at Weill Cornell Medical Center in New York City. Welcome, Dr. Ezra Gabbay, to the conversation.
Thank you very much for having me, Carl.
So let's get started with New York's Medical Aid in Dying, or MAID as it's known, officially goes into effect on August 5th. What is MAID?
Right. So before I start, let me just kind of quickly give two disclaimers that are both technical, but also important in their own right. So the first is I'm going to be sharing, a lot of personal opinions here about MAID and about other issues that we'll be talking about. But these opinions are my own, and they don't represent necessarily the opinion of the institution I work for or the ethics division at Weill Cornell. They're my own personal opinions. And then the other thing is that when people hear doctor, they are obviously, they want to know what that doctor has to say. But we're having a conversation that is hopefully going to help your viewers educate themselves and understand more about these issues. But by no means is any of what I'm about to say to be construed as medical advice. And since we're also going to be talking about some legal issues that certainly shouldn't be construed as legal advice. I am,
We should always go to your doctor.
Right. And as I always joke, yeah. my only legal training is that I've watched a lot of Law and Order, but beyond that, I've absolutely no legal credentials. But you should always I do have medical credentials, but this is not medical advice. Good. So now let's get back to your question. What is MAID? So there's a more kind of concrete answer to that, a more sort of bigger picture answer to that. So let's start with a concrete answer. You've kind of touched upon it. MAID stands for Medical Aid in Dying and refers to legal and procedural processes, if you will, that exist in several states in the United States that allow for patients who face what we call a terminal illness, an illness that is expected to lead to their death within 6 months, whether or not treatment is provided, ask their doctors to prescribe a set of medications that will end their lives, as you said. And it allows for the doctors with certain sets of safeguards to make sure that process is done right and to prevent problematic situations that we'll talk about. But it does allow doctors and other people who are involved in this process, such as pharmacists, et cetera. It allows doctors to give that prescription that patients take themselves. And this is how MAID, Medical Aid in Dying, is distinct from euthanasia. That is a subject that sometimes, or a term that sometimes comes up. Euthanasia happens when the doctor themselves administers the lethal medication. In MAID, the patient takes the medication themselves. And that medication brings about rapidly, probably varies a little bit from one patient to another, but whether it's minutes or hours, brings about that person's death. So that is sort of a very technical and concrete explanation. Go ahead. Yes.
Yeah, but this is not for someone who has dementia or Alzheimer's. This is someone who knows exactly what's going on.
So decision-making capacity is a big part of the safeguards that I mentioned. So in the U.S. and certainly New York State, but I to my knowledge, each and every one of the U.S. jurisdictions that allow MAID requires that this would be a voluntary process by an adult who has what we call decision-making capacity, sort of a fancy medical term as to basically say that the patient is with it, the patient is making an informed decision, they've thought it through, they understand the consequences of their decision, and they know that, what they should expect. So yes.
So what does the medical profession think of MAID?
So it's highly controversial. I'll share my own opinion in a little bit, but maybe we can kind of start with kind of as neutrally as I can to sort of describe the various opinions about MAID within the medical profession. So I would say I can't really give exact numbers or percentages, but I would say a significant percentage of physicians think that this is something that should be an option for patients, and a significant number of physicians disagree. And it's also true of medical organizations and medical societies. Some are more for it, some are against it. It's something that is controversial among different physicians, medical societies, and medical organizations. Now, if I were to try and represent why the opponents oppose it and why the supporters support it. So I think the supporters support it because they think that this is something that is congruent with what we call personal autonomy in medicine, that the idea that patients should be the ones driving and making the decisions regarding their own health, but even to the point of deciding how and when they want to end their lives when they're facing a terminal illness. The other argument that people make in favor of MAID is that the safeguards that are there, such as some of them we've mentioned already, having it be an adult with capacity, having very strict approval processes. In most cases, you need more than one. It rarely, if ever, falls to a single provider. Usually, there's more than one provider that approves the process, or always there's more than one provider that has to concur. There are waiting periods. For example, in New York, there's a 5-day waiting period between the writing of the prescription and when the pharmacy can fill that prescription, with maybe some exceptions. I won't get into that. There has to be, again, this is something unique to New York State, an oral request for MAID that has to be either video or audio recorded and stored in the patient's record, a mental health evaluation. This is, again, something that New York State is requiring, etc. I won't get into quite all the specific guardrails or provisions or safeguards, but there are several, and people can research that for themselves.
But
yes, go ahead.
Here's my concern is, Matthew Perry just died from a ketamine overdose that doctors were giving him the medicine for. And Michael Jackson used propofol because he couldn't sleep. What's there to say, I go convince my doctor, I'm depressed, I just want this to end, and here's $1 million. Right. So you don't, to end it early is my concern.
Right. So that's a great segue to introduce the position of the people who oppose medical aid in dying, both within the medical profession and outside it. So the opposition, so you kind of mentioned a couple of things. The first is, the potential for mistakes or for abuse or for, people for insufficient supervision about inappropriate use of MAID. We're giving physicians the power to essentially provide people with the means to kill themselves. So that's kind of one dimension of why people oppose it. Other reasons why people oppose it are, again, more sort of conviction-based, whether it's religious faith or whether it's just personal belief that doctors have a duty to preserve and uphold human life and not to end it, even if that's what the patient wants. It's really kind of if we kind of go into the ethics part of definition, there's a certain distinction between what we call rights ethics and duty or virtue-based ethics. So in modern medical ethics, and I would say particularly in American medical ethics, patient autonomy and patient choice really reigns supreme. It's one of several ethical principles, but it's really kind of a first among equals. American medical ethics is very much about patient autonomy and patient choice. And there are good reasons for that. And in principle, I think it's a very good thing. But what some of the opponents of medical aid in dying say is that it's very important to uphold patient autonomy, but physicians still have certain moral duties, moral convictions, core values that they must uphold, and they need to adhere to those. And, giving your patients a lethal combination of medications is not part of that. So that's one aspect of why people oppose it. I will maybe come out and say that I personally have very serious concerns about medical aid in dying, and it's something that I personally don't see myself as being part of or supporting as an individual physician. And I would say, at least, my understanding of medical aid in dying, and I'm being careful here because I'm not a lawyer, is that there would be room for physicians who feel uncomfortable or that it violates their values to participate in medical aid in dying. And the reason, my personal opinions and my personal reasons for opposing medical aid in dying, some of them have to do with the issues that I talked about, which is I do believe that human life is sacred and that it's our job as physicians to do what we can to preserve it and uphold it. I can understand why people facing a terminal illness will want to sort of exercise autonomy and choose the time and the circumstances in which they end their life. But it's hard for me to see my role as a physician to be part of that. The other issue that I want to really emphasize, and I think that this is something that a lot of people don't fully realize. When people, I feel that even the name, Shakespeare asked, what's in a name? Opponents of medical aid in dying actually call it physician-assisted suicide, whereas proponents usually call it medical aid in dying. And there's a lot of importance to that terminology, because I think sometimes when people hear the word medical aid in dying, they kind of envision somebody who's on their deathbed and actively within maybe hours to days dying, and you're just giving them, a little bit of extra medication to make that process a little bit easier. But that's really not the case. The case is you have somebody who could have up to 6 months more to live, and somebody who can be pretty functional at the moment and at least able to take the medications themselves, and you're giving them extremely high, or rather, if those physicians who will be prescribing the medical aid in dying protocol are giving extremely high doses of medications, orders of magnitude higher than usual therapeutic doses, sometimes 100 times higher, sometimes 1,000 times higher. I don't want to get too specific, but extremely high doses. And again, you have somebody who's, fully alive and conversational at, 1 o'clock, and by 3 or 4 o'clock, they will be dead because they took that combination of medications, or possibly even within a much shorter time. So I think that the active role, the reality of really providing people with the means to, kill themselves, if you will, I think that kind of harsh, sober reality I found when I kind of explained to people what medical aid in dying is, they really that these are the doses. So that's something that I think a lot of people don't understand, and I think that part of that misunderstanding may be very, very problematic.
One of the things I was thinking as I was listening to you talk there, your doctor can land up being, and I don't want to call it lazy, but if you know what's going to happen, right, and you're sitting there thinking like, okay, I know this is the diagnosis, I know where we're headed, then the doctor could be like, well, this is what's going to happen to you, and then you hear this. To me, I think I would want my doctor to keep fighting for me, because I want my doctor to know that I'm all in, and I want if this is my diagnosis.
So, the potential for that kind of moral lapse is there. Doctors are humans, and it could be whether it's like a conscious thing, which I think hopefully most conscientious doctors won't be saying that to themselves, but maybe even subconsciously. It's that risk is there. But what I want to say, and why I think that this is, even though I have a pretty clear opinion and position on the matter, I do want to represent fairly the side of people who are proponents of MAID. And a lot of people towards you say an hour of life is an hour of life, and that is true. But for a lot of people, an hour of life can represent excruciating, unbearable suffering, right? And a lot of our work in treating people with terminal illness is providing certain measures, whether it's by withholding or withdrawing with the patient's consent, of course, withholding or withdrawing certain aggressive treatments and allowing people to pass naturally when their time comes, and providing pain relief and other treatments that are not meant to cause the patient's death, but there's always some kind of trade-off in terms of risk. But what makes medical aid in dying distinct from these other interventions is, in those other interventions, the essence of it is the patient has a fatal illness that's progressing rapidly. We're not trying to hasten their death. We're only trying to treat their symptoms or allow them to refuse certain aggressive treatments. For example, some patients choose not to have resuscitation, what's called a do not resuscitate order, right? So if the patient makes that choice, and they have capacity, we respect that, but we're not the ones causing the cardiac arrest that's going to end their lives. What makes medical aid in dying distinct is that this is an active as it can be without really having the doctor administer the medication, but we really are actively providing people with that means to end their lives, that day. Yeah. So that is, it's important for me to explain that despite my clear misgivings about MAID, that the also needs to be understood in the context of the fact that it's extremely important to help people who face terminal illnesses. And I imagine many of the people watching and listening have seen loved ones struggle with enormous suffering at the end of their lives. And oftentimes people want to help their loved ones avoid excessive sufferings. But I do think that MAID is different in certain substantive ways. So yes.
And then I want to switch topics a little bit and talk about what is medical ethics. How would you define it?
Great question. So the way I would define medical ethics is as a medical discipline that deals with the effect of values on medical choices and medical decisions. And those values are often the values of patients or the patient's loved ones, what we call surrogate decision makers, or sometimes healthcare agents. And it sometimes is about the values of the people providing medical care, doctors, nurses, and others. I would define it as a medical discipline that deals with the values that drive choices made by patients and their patients' loved ones, their caretakers, as well as decisions made by clinicians, including nurses, doctors, and others. So that is what we try to do in medical ethics is help various stakeholders, as I mentioned, patients, surrogate decision makers, which usually means a relative or a close friend, as well as doctors and nurses, understand how the choices, the value-based choices that they need to make, whether as recipients or givers of medical care, how those values affect those choices and help bridge any questions or a feeling that there is a certain gap between the reality that that people face in certain medical situations and what they feel is the right thing to do. So it's our role as ethicists to help people reconcile and bridge those gaps and answer those questions when there's a certain tension between the two. The other thing I think, another aspect of medical ethics is that we, sometimes people think about ethicists as people who adjudicate between good and evil. that's not really what we do, right? We don't come after people and tell them, you're acting in an immoral way, I mean, but rather we recognize that people need to balance what we call competing goods. So, for example, we talked about patient autonomy, right? And having patients have the right to exercise their choices, whether it's to accept or refuse medical care. Sometimes patients refuse medical care, and that refusal can have enormous implications for their health. So, we're trying to when we as ethicists get called into a situation like that, we have to balance the good of the patient's autonomy with another good, which is the benefits that they may derive from the medical treatment that is being offered to them. So that's kind of the substance of our work in medical ethics.
And it seems like there could be contradictions. I'd come to the doctor. The doctor tells me I have dementia. I don't want anybody to know, and I don't want my loved ones to know. Now I'm caught up in this conundrum. You know what's going to happen, but I do need somebody to help me figure out, but I don't want that help. So that would be something that would come across your desk?
Correct. And then when, you mentioned, for example, the issue of dementia, right? So most of these, if not, so when patients are, you mentioned before with it, that is to say, when patients have decision-making capacity, it's generally a straightforward situation in that, they want certain treatments, then can accept it. If they don't want certain treatments, they can refuse it. What happens though when the patient has what we call impaired capacity? That is to say, whether it's due to dementia or to another condition, they're not quite able to reason as they would otherwise be able to. And I won't get into all the technical and procedural elements of capacity, but essentially, the idea of being able to make an informed choice, to understand and communicate the reasons behind that choice, and to understand its implications, right? So when patients lack decision-making capacity and are refusing certain medical interventions or making certain requests or expectations that we think are not the right ones for them, that's when things get complicated. And there's never an easy answer, because even when patients lack capacity, we want to make sure that to the highest degree possible, we still uphold and honor their autonomy and their personhood. So that's a very difficult balancing act.
Is that the most important thing, autonomy? Is that like the high standard, and then the others are not as they play lower on
Great
the
question.
in the
So I would be hard pressed to find somewhere where it's, somebody would write autonomy overrides all other ethical considerations. And I don't think that it does. But I will say that most ethical conundra, dilemmas, and a lot of what we deal with as medical ethicists do revolve around autonomy. Autonomy does have a certain central role, both in just how relevant it is to medical care and historically. So I think some of the reasons why autonomy became so central to medical ethics has to do with the history. If we think back on the history of the 20th century, if we think back about things like, the horrors of Nazism and the medical experiments that were done on Jewish prisoners in concentration camps and on other people during the Nazi period, or if we even think about other examples, such as here in the United States, there's the well-known case of the Tuskegee syphilis study, in which African American men in the South were denied, quite horribly and viciously, were denied treatment for syphilis because they were enrolled in a clinical trial, or it wasn't even a trial. It was basically a quote unquote academic, although I don't think that that's the right word for it. But these men were denied simple and effective treatment for syphilis because their doctors thought it was more important to study the course of that illness. So because of these historical violations of patients' right to exercise autonomy, autonomy became a very central tenet, a very central code of Western medical ethics in general and of American medical ethics in particular. So it's, as I said, it's kind of first among equals. There's no kind of formal way in which it supersedes other ethical considerations, but it's something that we pay very, very close attention to.
And then the big question I ask everyone, because it's playing such a big part in our lives, is AI. Do you see AI playing a role in medical ethics?
So, I think AI is going to be playing a role in everything, or already, to a large degree already is. And there are two big questions that we need to answer. I don't have answers to either of them. And the two questions are whether the use of AI in clinical medical work can be done ethically and what the safeguards for that should be. And the second major question is whether or not AI can support ethics work, whether AI can adjudicate or even serve as a tool for ethics consultants when they're faced with ethical questions. So, if you kind of think of the first question, then, I think it's complicated. I certainly think that the enormous power of AI in finding the correct information and to a degree analyzing it in a way that makes it very accessible and very easily usable has certain merits from an ethics perspective. Where it gets very tricky is that area where you really need individualized judgment. I'm not an expert on AI, but from what I do know on AI and large language models, they're essentially, you look at probabilities of answers to questions based on, a very, very wide internet search and analyzing the language of what they find. So, you can ask AI, what's the best antibiotic for this particular type of infection? And, there's more than a small probability that the answer will be a reasonable one. But when you ask questions such as, should I start the antibiotics on this patient or wait until I've got better proof for starting for there being an infection that requires antibiotics, that's really where AI can be wrong and not know that it's wrong. I think from an ethics perspective in this category, my biggest concern is that AI has very limited capacity for self-doubt, and that capacity for a healthy small dose of sprinkled self-doubt is an important part of medical practice. A good doctor, I believe, has to ask themselves, what if I'm wrong? How will I know that I'm wrong? And what will I do if I find out that I'm wrong? And I don't know that AI can really do that, or that's really part of its essence.
Well, you're an individual.
Correct.
So, and you have to look at you as an individual.
Yeah. Exactly. Then to the other question of, whether AI can be a good ethicist or not, I will say that there's a lot of interesting work being done on that and a lot of interesting research. I think here too, AI can provide ethicists with a certain understanding of what the current of the relevant medical information, and can maybe give them some tools as to how to sort of structure that information to help them through their thinking. But here too, it is absolutely vital that ethicists exercise their own judgment and their own understanding of the individual situation that they're facing and the implications of the choices that the people they're advising face. At the end of the day, AI is a machine. Probably the most powerful machine that human beings have ever created, and we're probably just at the beginning of it. But at the end of the day, I personally don't think that AI has consciousness or a true moral base. It's not something that can morally reason independently. I think it's
coded.
It's coded.
Done by a coder. There's a coder doing this.
Somebody that can, it's somebody, that may be a Freudian slip there, right? It's a thing, it's a machine that could very easily summarize humanity's existing knowledge about subject and give you a certain synopsis of it that can help you, but it doesn't really have, uh, um, you know, I think it doesn't really have authentic doubt, authentic guilt, authentic sense of right and wrong. All of the
Yeah.
things that ethicists need, I don't think that machine truly does. It's really good at pretending it does, but I don't really think that it inherently does.
Do you want to talk about the medical ethics and religion and how the two components work together?
So, a lot of my academic work has been studying how people's religious values and cultural values interact with their medical choices for themselves or for their loved ones. I'm particularly interested in what we call the Haredi or the ultra Orthodox Jewish community and how the code of beliefs and behaviors and social norms of those communities interacts with their choices regarding medical care, whether it's sort of regular medical care, mental health, medical care, care at the end of life, which kind of relates to some of the things that we talked about, and other aspects of care. And that's something that I've always found very, very interesting.
Dr. Ezra Gabbay, Associate Professor and Senior Clinical Ethicist at Weill Cornell Medical Center in New York City. Thank you so much for joining me today. Thank you so much for listening. As always, let me know what you think. Put your thoughts in the comment section. And as I always say, until next time, be safe.